Hello and welcome to our IVF webinar. Once again, it's 5 p.m. UK time, so it's a bit different time, but I hope that you are ready to learn a bit more. And of course, as always, ask your questions. And we are here once again with wonderful Dr. Anna Voskuilen. I am very happy to have you back. It's been a while, so thank you so much for joining us once again. Dr. Anna, how are you feeling tonight?
Very well, thank you. Thanks for inviting me. How are you? Everything fine?
Yes, I am very happy to have you here for sure. And I just want to mention that, as I mentioned actually already, Dr. Anna has been with us already. And there was another topic that she prepared last time. It was, I remember, on PRP. This time she will be talking about understanding fertility and ovulation. And of course, we will start with Dr. Anna's presentation on that topic. And afterwards, as always, you will have a chance to ask your questions. You can do it now, later on, and I'm sure Dr. Anna will be happy to answer any of the questions that you will have. And Dr. Anna is a specialist in obstetrics, gynecology and reproductive medicine, of course, at Reproclinic, which is located in beautiful Barcelona. So thank you so much once more. And I guess, let's go ahead with our presentation. And are you ready to begin, Dr. Anna?
Ready to begin, yes.
Let's start then. Thank you so much. And let me put the presentation here.
Okay, so tonight's topic is understanding fertility and ovulation. So it's a guide for patients trying to conceive. I will try to explain some different things about it, and I will try to be clear and to answer all the questions that you have. So let's start with some general aspects of fertility that I normally explain to the patients when I have them here in the fertility clinic. So the first thing that we should know, probably you have heard about it before, women are born with a certain ovarian reserve, and this ovarian reserve decreases with age, and this decrease is more important after the age of 35, 37, and also it goes related to a decrease in terms of the oocyte quality, of the egg quality. Okay, so we can test the ovarian reserve, the total amount of reserve, but we cannot test the egg quality. Okay, there's no test to see it. So what we do know is after 40 years old, there's a difficulty in getting pregnant, a higher rate of miscarriages and more chromosomal abnormalities in embryos. We do know that. And this goes related with the age. And what can we test? So what are the ovarian reserve tests that we have? FSH and estradiol. Actually, the FSH is the one that is important, but we need the estradiol to interpret the FSH levels. This is depending on the moment of the cycle. I always tell my patients that it's like the fuel of the ovaries. And if it's too high, it means that this ovary is not working properly and needs more fuel. Okay, so high FSH is not a good thing. Okay. Then we have the AMH, which is produced by preantral and small antral follicles, and it can be tested in any moment of the cycle. And it gives us an idea of the total amount of ovarian reserve that we have. And then we have, of course, the ultrasound, which is doing what's called the antral follicle count. What is that? So we know that in the beginning of our cycles, we have different follicles that could grow in response to the hormones, and that we can see with the ultrasound because they have a little bit of liquid. Okay, so if we count the number of antral follicles that we have in the ovaries, we can have an idea of how the ovarian reserve is. And what happens in a natural cycle? We have different follicles available to grow, as I said, but just one of them will grow in response to the hormones because we don't have hormones to make all of them grow. Okay, so we will lose the other ones, and actually we know that every month we lose a lot of follicles. Even if you're not ovulating, then we lose also a lot of follicles every month. And the development of the follicles, I want to say that it's not just 14 days that I will explain you later, but it starts 3-4 months before the ovulation. So it's important to know it because everything that we can change in our lifestyle could could have an impact on that, okay? And these phases of the follicles are divided into phases. One is the independent of the hormones, and the other one is dependent of the hormones, is the one that we are going to see during these 14 days before ovulation. That is the growth of the follicle and the ovulation, okay? Saying that, how does this work? How is this controlled? So there's the hypothalamic pituitary ovarian axis. So the menstrual cycle is regulated at the central nervous system, okay? So some people say, how comes that I have menstruations every 28 days or 32? How does my body know when I need to have my menstruation, okay? So here we have the explanation. It is regulated by the central nervous system, and the first level will be the hypothalamus, that produces GnRH, which stands for gonadotropin releasing hormone, and it produces these GnRH pulses that will vary in frequency and amplitude and will stimulate the gonadotropins, will stimulate the anterior pituitary gland to produce gonadotropins, which are the FSH and LH. FSH stands for follicle stimulating hormone, and LH for luteinizing hormone. And these hormones are going to stimulate the ovaries, and the ovaries are going to produce several hormones that will also have an impact on the other previous phases of the cycle, sorry. So it will have an impact on the production of GnRH in the hypothalamus and also in the production of FSH, and that's kind of a circle that happens, and that is in that way to control all the cycle, okay? That's the way in which our body controls everything, with feedbacks, of positive feedback, negative feedback in different structures of our system. And also, let's say that some external stimuli could affect the hypothalamus and could change this axis, like stress, lack of sleep, sudden weight loss, or excessive exercise. And all this could create irregularity in our menses. So now let's go to the genital tract. Let's be a little bit more in that point, okay? So I will divide it in two phases, two different things. The follicular development, which is the development of the follicle in the ovary. And then the other part is the endometrial development, which is the growing of the lining of the endometrium that is inside the uterine cavity, and that will grow and then that will actually create the menstruation if we don't get pregnant, okay? So with cycles of 21 or 35 days, usually we think that they are ovulatory, so that we have an ovulation in them. So what happens normally in a cycle? First of all, as I said, we have different follicles available to grow, and they're like fighting for the FSH hormone. And then the FSH levels go a little bit down, and one follicle is selected like the dominant follicle, and we lose the other ones. And this one is the one that's going to grow and is going to ovulate later, okay? And while this is growing, this follicle is growing, it produces estrogens. And these estrogens, as you can see, will increase progressively. And the impact of the estrogens on the endometrial development will be that after menstruation starts the proliferative phase of the endometrium that is in response of these estrogens that produces this follicle, the endometrium lining will grow, okay? Then also these estrogens, this peak of estrogens will create the peak of LH and FSH, and the LH is the one that's going to be the one responsible for the ovulation, okay? And after this peak, we will have the ovulation. This egg will travel to the tube, to the fallopian tube. If we have sexual intercourse, the spermatozoids will swim up until the tube, and if there's fertilization, the embryo will be produced in the tube and then will travel until the uterine cavity, and there he will implant on the endometrium, okay? So what happens after the ovulation? Apart from that, what happens in the ovary? We will have a scar in the ovary, which is the corpus luteum that produces progesterone. So So what we see is that after ovulation, the progesterone is going to rise, okay? And this progesterone will be also responsible for changing the endometrium, okay? So giving a maturation of the endometrium so that the endometrium can receive the embryo and let the embryo implant, okay? So that would be more or less what happens in our cycles. And now some tips about ovulation and fertilization. So ideally, to have a general idea of what we have to do to try to conceive, okay? We should have sexual intercourse as close to ovulation as possible, but it's true that we are not a clock, so it's not easy to know exactly when you're ovulating. So you should know that ovulation takes place approximately 14 days before your period. And I say before your period because we know that the luteal phase, which is the phase after the ovulation, normally it's very stabil. So we know that 14 days before the ovulation takes place, okay? In longer periods, for example, or shorter periods, what normally varies is the follicular phase, okay? So that's why we count from the menses 14 days before, okay? So another important thing to know is that the egg has the possibility of surviving for 12 or 24 hours, okay? And that sperm can survive between 2 and 5 days in the female genital tract. So therefore, it is recommended to start intercourse at least 4 or 5 days before the middle of the cycle, okay? And then, or actually the date in which you think you're going to ovulate approximately, so that the sperm is waiting for the egg, and to have sexual intercourse every other day or even also daily. Some different things that you can check, some signs of ovulation that we can see. On one hand, to time the ovulation to see when we are ovulating and to see when we could have sexual intercourse with the best chances, we can look at the vaginal discharge. So normally, right before ovulation, because we have this peak of estrogens, we have a vaginal discharge that is clear and stretchy, okay? This is something that we can see, but of course it can vary if we have any infection or anything, or I mean, if it can change a little bit. It's not very, very accurate, but it's something that you can look at. And we can look at also at other natural signs like pelvic discomfort, a little bit of pain. Some people feel it when they are ovulating, okay? Also, some people tell that they have emotional changes. It's also described an increased libido, okay, which is very normal. Actually, it should be like that. Nature knows a lot and is wise. Okay, and then other things that happens during or quite soon before ovulation are the LH and estrogen peak that we could test with different in blood, in urine, etc. And then also with serial ultrasounds, we could see how this follicle is growing and how it is close to the ovulation. Okay. And things that you could see after ovulation, okay? So after ovulation, we know that, so these ones are the ones to know a little bit more about yourself, to know your body a little bit better. What we do know is that the body temperature will increase because the corpus luteum, that was this card that I told you in the ovary after ovulation, produces progesterone, and this stimulates the central nervous system to increase the temperature of the body. Okay, and then also we can test progesterone levels in mid-luteal phase, which is 7 days after ovulation, and see if it's positive or not. And with that, we can be sure that if we have ovulated or not. Another thing that we could do at home, actually, what could we do at home? The LH tests that are based on the detection of the LH surge in urine, and actually this must be done from 4 or 5 days before the middle of the cycle or before the time that you think that you're going to ovulate. So it would be great to charter some previous months to take in consideration these 14 days previous to the menstruation, so that you can count more or less in which days you normally are ovulating, okay? And then ideally it would be done every 12 hours or 24 hours to avoid missing shorter peaks, okay? Every 12 hours probably we will see the peak. And also, another thing that we should know is that there are false negative because of short peaks. So the peak is so short that we miss it with this test. And also it depends on the accuracy of the test. And also that there are false positives, which means that you have a positive test, but you are not ovulating. When can this happen? In patients with polycystic ovarian syndrome, we can see some patients that have elevated LH levels from the beginning of the cycle. So they can have a very long LH positive test, and it doesn't mean that they're ovulating. Okay. And also in menopause, in premature ovarian failure, we could have also a positive LH test during all the days. Why? Because, as I said, FSH and actually also LH are like the fuel of the ovaries. And if the ovaries are not working at all, like in menopause or premature ovarian failure, our central nervous system will give more fuel. So the LH will increase a lot and will give a false positive test. Okay, so it's better to test with these urine tests that see the estrogen levels and the LH levels. Okay, because then we will find the estrogen peak and the LH peak, and this means that we are going to ovulate. So now, preparation for fertility, a little bit of lifestyle. What would I say? In general, carry out a lifestyle as healthy as possible. So varied diet, fresh food, unprocessed foods, avoid toxics, of course, and avoid also sedentary lifestyle that can have an impact. So do a moderate physical exercise. Have a little bit of activity. Okay. If you have any medical conditions or any medical problem, contact your doctor, because it could be interesting. It would be very interesting to be sure that you are on the best conditions to try to conceive. And if you need any change on the medication or anything like that, it would be interesting to do it before. Also, there are other types of treatments that have been postulated as possible aids for quality improvement of the eggs, but this is more for assisted reproductive techniques like melatonin, CoQ10, all these things, but there's no a strong, consistent scientific evidence to say that it really helps a lot, okay, to change the quality or possibilities of achieving a pregnancy, and at least not in normal fertility, okay, in trying naturally at home, okay. And another interesting thing I would say is that there are no differences in positions during sexual intercourse, nor staying in supine position after having sexual intercourse, okay, so no differences in pregnancy rates. So after that, about diet, which is very important. So all these lifestyle things, I mean, are important because everything that we can change before will help can help the quality of the eggs and can increase our chances, okay? But it's true that diet has not demonstrated that it can improve a lot the quality of the eggs or things like that. But it's something that we think it's important to have a very varied and equilibrated diet, to eat complex carbohydrates, more rice, potatoes, things like that, monounsaturated fats, omega fatty acids, fresh vegetables and fruits, nuts, cereals, blowfish, also meat, okay, better eat things that are organic. And it's very important, the folic acid, vitamin B6 and B12. I mean, it's more, what I want to say is related to B12. In vegan people, they can have a deficiency of B12 vitamin. So it's important to supplement with this vitamin. Normally they are supplemented, vegan people, okay? With vegetarian people, it's not a problem because they take eggs and dairy, so it should not be a problem. And then another thing is avoid what I had said, no? Avoid processed foods, saturated fats, sugary drinks, so have a healthy diet. And talking about folic acid, which is very important, okay, so that's the thing that I will tell you that you need to start before trying to conceive, okay. Folic acid is very important for the nervous system formation, for the closure of the neural tube, and this happens early during pregnancy. So it's important to have these levels correct before, okay, before knowing that we are pregnant. Where can we find it? In green leafy vegetables, citrus, legumes, liver, seafood, blue fish, but more in vegetables than in foods of animal origin. And another thing is it's better to steam or eat crude or raw these vegetables than cook or freeze them, because the amount of folic acid can decrease. And then what I told you, right? So it's important to start a preconception multivitamin or a folic acid supplement to make sure that the levels are correct when you're looking for a pregnancy. Weight. So weight is also important. What we counsel is to have a normal BMI. So it should be between 18 and 25, okay? What I just told you, variations in diet have not actually been shown an influence on the results, more in assisted reproductive techniques, okay, because we have more data on that. But what has been shown to improve the results is having a correct BMI, okay, before ART. What we do know is with patients with normal fertility, right? In patients with very low BMI, we could have an ovulation problems because your body thinks that you're under stress, you don't have enough food, okay? So actually, that's the reason why you don't ovulate, because the body thinks that it's not the best condition to get pregnant, okay? And in obese patients, what we can find is irregular periods. Obese would be more than 30 of BMI, okay? So we can have irregular periods, increased risk of insulin resistance, more miscarriage rates, complications during pregnancy, okay? And more complicated deliveries. So it's recommended to contact a nutritionist when we have an abnormal body mass index. So to try to have the best conditions and to have the best outcomes, also for pregnancy, actually giving birth, all of that. And now about vitamin D. So what we have about vitamin D, I don't know what we cannot see it, but I will explain it. So we can get the vitamin D with the food intake, okay? But this is normally insufficient. It will be liver cuts or things like that, okay? I always remember my dad from the Netherlands, and he always tell me that when he was little, his mom gave him cod liver, and it was horrible to supplement the vitamin D, okay? And the other source that we have of vitamin D is the sun, okay? So that's why we have this picture of the sun. And we synthesize the vitamin D in our skin in response to the ultraviolet rays, okay? So the best thing would be at least being 30 minutes under the sun, okay, with arms and legs exposed, or back also, to try to have a good level. And actually it's important because it has an important role in phosphocalcium metabolism, in immunological aspect system, okay? We know that it has an important role, and that it also can have an important role in fertility, because it can have an impact. It could have an impact on natural fertility and also in the quality of the eggs, and when we do assisted reproductive techniques, in the implantation rates that we can have. And normally we try to have levels of more than 30. That would be the correct levels. If it's under 30, we normally treat it, but we know actually what has been demonstrated is that lower than 20 is what can give us a little bit more problems regarding to fertility, okay? But less than 30, we normally treat it because it's easy and it's not harmful. Of course, we need to continue testing if this supplement of vitamins is correct. We normally give like 2,000 units more or less, okay? And or 1,000. It depends on the levels that we see and on all the how quickly you want to resolve that, okay? And of course, that what I was saying, we normally test these levels every 4 weeks or something like that, to make sure that the levels are correct and not too high. I didn't see any patient with too high levels, but still, I mean, it's a supplement, so it's good to control it. About alcohol and drugs. So about alcohol, it can have an inhibitory effect at the central nervous system, and this can have an effect on at the testicular level, irregular menses, quality of the oocytes. It could also have in man it can create an increased DNA fragmentation of the spermatozoid, so that the genetic material of the spermatozoids is altered, it's fragmented, okay, and this could be related with more miscarriage rates. It could have an impact on morphology and count, okay. What we know is it is not, what we know is that it is dose dependent, okay, so it depends on how much you drink. From 8 weeks, it could be from 8 weeks, 8 units a week, sorry, of alcohol. It could have a negative impact, as I am telling, okay. 1 small glass of wine is 1.5 units, more or less. So actually, it's something a little bit, I mean, controversial. I mean, all these negative effects have been demonstrated in very high levels. So low levels of alcohol during the week, I mean, like moderate intake, it's necessarily not going to have a big impact on fertility, okay? So I would say like once a week, drink a glass of wine or things like that. It should not be very important. So that's what I counsel my patients, okay? But it is true that during pregnancy, I totally, absolutely, we should avoid it, okay? Because it can create malformations on the embryos. It can give problems. So it's very important to avoid it during pregnancy. That's something that we do know, and we know that it can have a big impact. And then talking about other kind of drugs, marijuana, cocaine, androgen steroids, they can also negatively impact the gonadal function. So these axes that I was talking about before can be altered by this. And then also we can find problems with motility and morphology of sperms in men. In women, we can have ectopic pregnancy, miscarriages, less embryos to transfer when we are doing ART techniques, so assisted reproductive techniques, okay? And cocaine also, what we have seen is that it's during pregnancy, it's something that could be a big problem, okay? It could give miscarriage and abruptio placenta, so very important problems with placenta and to do a C-section, urgent C-section, okay? So it's something that we need to avoid, all these drugs. And another interesting point is that androgen steroids can create azoospermia. What is that? Azoospermia is the lack of spermatozoids in the sperm sample. And the androgen steroids can be found in, there are some men that go a lot to the gym and want to grow their muscles a lot. So if they take any supplement with steroids, this could have an impact on the axis that I were explaining. So they can have a negative impact and they can inhibit the function of the testicles, okay? So that's why we cannot see spermatozoids on the sperm, and normally it's something that that we can reverse, okay? And then related with caffeine, we should avoid excessive intake. It is something that it's a little bit controversial, but we always say like 1 or 2 coffees a day would be okay for our patients. And it could have an impact if we take a lot of coffees in DNA fragmentation of the sperm, of the spermatozoids, and this could be related also with miscarriages. So smoking, we do know also that smoking can have a negative impact on the quality of the eggs, on the gonadal function, in follicular development. What we know in general fertility is that it can decrease the ovarian reserve. It's clear. I mean, smoking has a clear impact on fertility. Okay, and also we have seen that patients that smoke probably will have their menopause before patients that don't smoke. Okay, and it can also have an impact on tubal function. Of course, during pregnancy, it can create more miscarriages during pregnancy. Placental dysfunction, that means that the placenta doesn't work correctly, so the embryo and the baby doesn't grow as it should be. And in assisted reproductive techniques, we could have less oocytes and less quality embryos. And then in men, of course, this oxidative stress that can affect women and men. In men, what creates is a DNA fragmentation again of the spermatozoids, and this can create lower progressive motility. The progressive motility is the ones that are moving ahead. Okay, so the spermatozoids can move vibrating or doing cycles. The ones that are interesting are the ones that go ahead. Okay, this is the progressive motility. And also it could lead to an embryo blockage, lower quality embryos, lower pregnancy rates. So now about stress and exercise. So chronic stress could have an impact on our general axis, on our central nervous system, and it could have a decrease in the hypothalamic function, okay, in the GnRH, and it can also decrease the libido, okay, which is also very important for natural fertility. And in psychological stress, actually, in assisted reproductive techniques, the implication has not been clearly demonstrated, and I think it's because it's not that easy to do big randomized trials with psychological tests with patients. I mean, probably that's why we don't have strong evidence that it can affect or not, okay, but we do know that in specific patients, it can have an impact, and more in assisted reproductive techniques, there's a lot of emotional involvement. So they probably will need a help from a coach, psychologist. So it's important to try to manage it with something that we like to do, like, I don't know, exercising, for example, that is the next point, or reading a book, or doing a bath, or whatever that can relax us and that can help us to be a little bit less stressed, okay? And exercise, I would say do a moderate exercise and not extenuating, so not strenuous, because it can help regulate menstruation. So it's good to be active, and especially in overweight or obese patients with polycystic ovarian syndrome, and because in that patients, a little bit of exercise can also help to reduce insulin resistance, and also, of course, it can help with the BMI of the patient. And then also know that if it's too much or too extenuating, it can create irregular cycles or amenorrhea. Amenorrhea is the lack of the menses, and it can also modify some seminal parameters. Okay, so it's good to be moderate and be active, actually, when you're trying to conceive, and naturally or with assisted reproductive techniques. And then also say that men should avoid cycling a lot of hours, and actually more in mountain and things like that, because it can impact the scrotal zone. So that could have a negative impact. So that's a recommendation, actually. And also avoid high temperature, which is not exercise, but it can come after exercise. So avoid sauna, okay? Because it's better to don't have very high temperatures in the scrotal zone, the testicles. And also, let's say that exercise is very important physically, but also it's something that can help us emotionally, okay, to manage all the stress that we could have. And what happens if we don't have a success? So you should contact a gynecologist 12 months after trying to conceive, 6 months after trying from 35 years onwards, because age is an important factor. And also before, if there's some known problem, like endometriosis, inflammatory pelvic disease, male factor, or other diseases that could have an impact in fertility. So to summarize a little bit everything, just try to have a healthy lifestyle, so varied diet, a little bit of exercise, try to stay active, avoid toxics. Probably 1 or 2 coffees a day will not make any difference, or 1 unit of alcohol I mean, once in a week, something like that, probably would not have a big impact as well. Try to do what I said, a little bit of exercise, don't be sedentary. And then knowing your cycle and trying from 5 days before the probable ovulation, okay, and trying every 1 or 2 days. So having sexual intercourse every 1 or 2 days. We do know that there's no differences between coital positions. I would tell you, be aware of natural signs of ovulation that you can feel in your body. Also, we have apps, LH tests, different things that we could use to try to help us. But the truth is that it didn't show a better outcome related to just a repeat intercourse during the 6 days of fertile window. And we'll try to enjoy. And if it doesn't happen, then just ask a doctor. And I think thank you and good luck with trying.
Once again for joining us and of presentation today, but also very useful.
Sorry, I don't hear you now. I don't know if everybody can hear you, Caroline.
Please let me know if anyone else has a problem. I hope now you will be able to hear me.
Yes, now.
Okay, sorry. But I'm here, of course. Thank you so much. I'm sorry for the little mix-up when it comes to the presentation, but of course, it's all good. I hope I was able to fix this later on, so you were able to see it. But of course, yeah, all is good, of course. Thank you so much. And as you can see, Dr. Anna, as always, lots of questions are coming in. So let's not waste time and let's start with the questions, okay?
Okay.
Excellent. The first question from Margie is right here. So when in a cycle the follicles start growing, asking because some stimulation cycles sometimes start on day 2, others on day 3.
So this is a good question. Actually, there's no specific day of the follicle to start growing. It's true that in some specific cases, we start stimulation when we do IVF, for example, or also when we do insemination before or later. Some people prefer to start at day 2, depending on every person. We start on day 3. So it's something that it's not absolutely. We don't have a just one day in which these follicles starts to grow. So that's why actually more or less between day 2 and day 3, there's not a big differences. I think it depends a lot on the ovarian reserve of the patient and on what we want to do. So with insemination, I would start day 3, and with someone that, for example, wants to do an IVF with a low ovarian reserve, I would start at day 2, okay, to avoid asynchrony of the follicles and things like that.
Okay, thank you so much for the very first question, Margie. And let's have a look. Okay, we have more of those coming up. What make many follicles grow during stimulation? The amount of FSH, how to define the FSH daily dosage based on the AFC, how to make sure that the selection of dominant follicle doesn't take place and all the follicle grow.
Okay, that are good questions. It's general IVF treatments, actually. So the thing is that what we have in a natural cycle is FSH that makes grow a little bit different cycles when they are very small, okay? But then these FSH levels start to decrease a little bit, and just the follicle that is the dominant one because it has more receptors for the FSH than the other ones, this one is going to keep all the FSH, and this one is the one that's going to be able to grow. So how do we do it to make more than one grow? Just giving more FSH. I mean, we give external FSH levels to try to give hormones for all the follicles, okay? Of course, it's not mathematics. It doesn't mean that even if we do if we give you a correct dose, all them are going to grow, because it depends a lot on your response, on every patient. It's very different, okay? But the thing is, we give more FSH to try to make all of them grow, okay, within a security for the patient, of course. How to define the FSH that we give daily, like with injections, with IVF treatments, or even with insemination, because in insemination we can also give a little bit of stimulation to try to increase the outcomes. This is based on different things: the antral follicle count, the age, the weight, the body mass index, okay, which is also important, and also if you have done previous cycles. So we can have an idea, but if you, for example, have done another cycle that went well or wrong, or this can give us an idea of how to change it and which dose do you need, or which kind of medication doesn't work with you, okay? So how to make sure that this selection of the dominant follicle doesn't take place so that we can make all of them grow? So giving more hormones, more FSH levels, starting the stimulation soon, I would say, more in people that have a low ovarian reserve, because when we have low ovarian reserve, we have higher levels of FSH, okay, because the fuel is higher, okay, for the ovaries. So that means that mostly what happens when we have low ovarian reserve and high FSH levels, the cycle shortens. And why does the cycle shortens? Because the follicular growth starts before that it should, so before the menstruation, okay? And this can lead to a process in which we stimulate your ovaries, but one follicle has already been selected, okay? And then we have what's called the asynchrony, even if we are giving you a lot of or enough FSH. So to manage that, normally we give a preparation before the menstruation, before starting the IVF treatments, if we think it is necessary, and it depends on every case and on every patient.
And again, thank you so much for yet another definitely interesting question, and of course for your explanation to this one. Okay, and I guess let's have a look at the next question. So what is the normal life for fertility? 26, 27 is okay?
The normal would be more between 18 and 25. After 25, there's a little bit of overweight, but it's not something that has been demonstrated that it can have an impact. So what we do know is less than 18 could have an impact. More than 30 could have an impact. And actually the best thing would be having a 25 maximum, but 26, 27, actually there's no conclusive evidence that says that this can have an impact. Okay, so probably it's not going to be a bad BMI. Okay, but it's also important is to do a healthy lifestyle and do exercise. Okay, even if we have a little bit of overweight, and it can also help in that sense.
Understood. Thank you so much for the clarification here. Okay, Angela has another question. So what is the chance of having any good eggs at 44 and AMH of 11?
11, probably it's talking about like moles, I think. So actually the thing is, the probabilities of having good eggs with 44 years old are very low. Okay, so what we do know is that actually after the age of 43, and actually with 43 also already, we start to recommend our patients to go for egg donation. Why? Because we know that the probabilities of having a success are very low. Okay, less than 5%. It is true that it depends on every patient. It depends, of course, on the AMH amount, everything, but it's something that I mean, we have to be very clear. Quality goes related with age, and this is the reason why we know that the probabilities will be low. The thing is that we cannot test the quality, as I told you. So probably if you have a good ovarian reserve with 44 years old, I mean, probably I would ask you for more tests, the FSH levels, the antral follicle count. I would test more things to see how everything is. I would also take in consideration if you have done treatments before or for how long you have been looking, okay, because it can give you also ideas, okay? But still, I mean, we do know that after 43, the quality becomes much worse, okay? And the probabilities of having good eggs are less than 5%.
All right, again, thank you so much for that explanation. And let's have a look. Okay, next one is a bit of a longer question. Could you please let me know what it means if there is a positive result for cytomegalovirus of 132.2 positive, also positive for chlamydia, when 1.1 is positive and erythrocytes is 10.5, when the range is 5.9, 9.90 in a pregnant woman?
Okay, so let's start.
Yes, of course.
Phase by phase. So step by step, sorry. So let's see. First thing is, it's very important. I mean, probably you're pregnant and then they have done all these tests on you, this blood test. So one thing that is important is also the symptoms, if you have any symptom or any problem. It's just probably a normal blood test. What we look at when we look at the cytomegalovirus is a virus that can have a big impact if you get it being pregnant, okay? So what we look at is the Igg antibodies, okay, and the IgM antibodies, okay? So actually, if you have Igg antibodies that are positive before the pregnancy, it means that an IgM negative, it means that you're immunized, so that you had this cytomegalovirus virus before, years before, months before, okay, and that you are immune to it, okay. This is something, it's a virus that it's very typical in children that go to the kindergarten, okay, so very little children, and probably you got that before. It could be because of one child that you had before, or it could be because you had it when you were a child, okay. So actually, with just an IgG positive test, if the IgM is negative, it means that you're immune for it, so that you don't have this high risk of getting it during pregnancy, okay? There's also the possibility of reactivation, but this is a low probability of having an impact on the baby, okay? And it's also not very frequent. So actually, in this sense, it is correct. Then positive for chlamydia, when it was, it could have, I mean, there are different tests for chlamydia, so it could be something that you had in the past, okay? For sure, I will consult to look at it with your obstetrician, so to look at everything super carefully and look if everything is correct, okay? For the chlamydia, normally it's better to do PCR test in the cervix because it's more accurate, and because some antibodies of chlamydia can stay positive because you had it in the past, for example, or it can be also that there are some cross reactions and it's a false positive. But it's something that we should look at, okay? I think it's just because you had it probably in the past, but it depends on exactly on which test they have done and all your signs and everything, okay? But probably it's something about the past. And then about the erythrocytes, I think it's not a very important thing about the erythrocytes. We know that during pregnancy, but again, I would contact my obstetrician and hear what he or she needs to, what he thinks about it, okay? What we do know during pregnancy is that we normally have a change in the hemogram, that we can have more anemia, okay, or actually the levels of hemoglobin, for example, lower down a little bit. So that's also a reason why during pregnancy, normally, also it's something that we can do after the second trimester or from the second trimester and on, we can take a little bit of iron supplements for the hemogram. That we also think that it's important.
Thank you for the detailed question indeed, and of course for detailed answer to it as well. Okay, let's have a look at the next question, this time a shorter one. Could beta blocker affect fertility in women?
I'm not sure about that. I didn't read about beta blockers affecting fertility, so I think probably not, that it doesn't have an impact on fertility in women, but I probably should look a little bit more data about it. But if I had to say something, I would say probably not, okay?
Okay, of course, understood. Thank you for that. And there's a thank you from Angela from our previous patient and in regards to the previous question, of course. Okay, next one is right here. So could painkiller drug like ibuprofen taken for a short time affect fertility?
So this is interesting because sometimes it could affect the ovulation. It could have an impact on the ovulation, it's true, because all the process that takes place in the ovulation and the endometrium and everything needs some different metabolism and chemicals from the body, okay, to release this egg from the follicle. All this needs a lot of process with prostaglandins and different things, okay. And it's true that ibuprofen stops the prostaglandins, so it could have an impact. I think, I mean, probably it's not very important, but normally we try to, we tell our patients to avoid ibuprofen during fertility treatments, okay, for that kind of reasons. Probably in a natural cycle, if you're trying at home and you take one day ibuprofen, I mean, it would be bad luck that it affects a lot, okay, at this cycle. But we do know that when we are doing assisted reproductive techniques, sometimes we recommend, I mean, not sometimes, we recommend to try to avoid ibuprofen.
All right, thank you so much for the clarification, of course, to this one as well. Okay, next one is definitely something we hear quite often. How fast does AMH drop after 39 each year?
That's a good question. It's a very good question. I mean, we do know that AMH drops, but it depends on every patient. So we don't know if you're the one that's going to have a big drop in 1 year or in 6 months. Probably there will be a drop, but not very, very important with the 39, but still, it depends on every patient. And the more time that goes on, I mean, with 40, 41, 42, every time this drop is faster, okay? Sometimes people ask me, like, when they have low ovarian reserve, they ask me, is it that I had a very fast drop or what happened? So we cannot know if they had like a very fast drop or if they have from the basal, they have less ovarian reserve, okay, from the beginning of their lives. And same thing with that. So we don't know how fast your AMH will drop after 39 each year. But probably, I mean, if you're thinking of trying to conceive, I will strongly recommend you to start already, okay, to avoid any other problems with this decrease of ovarian reserve.
All right, thank you for that. Definitely helpful. Okay, let's have a look. Next question is here from Anna this time. Every month during ovulation, I get bladder pain and a heavy dual abdominal pain lasting 2 days. I never had that before. What would be the cause of that? Would this prevent implantation?
So that's a good question. I mean, during ovulation, all this, there's like a movement of the genital tract. Also, there can be some contraction, or maybe when you ovulate, there's like a little bit of the ovaries is like, you know, moving a little bit, and this creates a little bit of abdominal discomfort. Actually, if you have heavy abdominal pain for 2 days, or you have like bladder pain, all these things probably are related to this ovulation, to a not normal ovulation, but something has happened with your body, because we are always changing. Okay, so it's probably something interesting to look at. I mean, to do an ultrasound with your gynecologist to make sure that everything is correct, that there's no cyst or no other thing that could be giving you this pain. Okay, and if everything is correct, I would say body changes a lot, and the anatomy changes also, so it can vary a little bit. And some patients tell me that when they have had children, then after having one child, then they have worse pain of the menstrual pains or ovulation. So this is because the body is continuously moving and changing a little bit. Okay, so it can be that, but absolutely I would check it with my gynecologist to make sure that everything is correct, and that's it. Okay.
Okay, of course. Thank you so much for that advice. Okay, more questions. Like 3 questions are left. We will be slowly finishing. So if you have anything else to add, just go ahead and type those in. And the question is it normal to have progesterone levels fluctuate between 12-18 nanograms per millimeter 4 to 7 days post peak fertility?
Yes, it's something that we know that we can see because when we have this progesterone created from the corpus luteum, it is because the central nervous system gives some pulses of LH continuously also, and there's like these pulses during the luteal phase are varying, and this can create a variation of the progesterone levels. Okay. But I would say if it's more than 6, it is telling us that you've ovulated, okay? And actually, these are correct levels of progesterone, okay? So don't worry about that.
All right, thank you for that. And of course, there's a thank you from the patient for you right here. And yeah, next question again, a short one. So is low carb diet good for fertility?
It's a good question. I mean, I think what you should have is a normal carb diet, okay? Not excessive, also not a low carb diet, okay? I think the most regulated one with a lot of food, a lot of variety food, fresh food more than processed foods, as I told you before. And probably what I tell you, better a normal carb diet than a low carb diet. I'm not an expert on nutrition, I have to say, but that's what we normally recommend, and that's what the evidence tells us.
All right, excellent. Thank you so much for that. And one more here. I was given ibuprofen after egg retrieval as painkiller. It was a egg retrieval cycle only at the time, so it won't have any impact on fertility.
No, I mean, if you have it like once and after the egg retrieval, I think it's not having a big impact on the quality, on the fertility. Okay. Also, it has it's a little bit controversial if it has an impact or not on endometrium. But if it was just only at the time, I mean, it's not something that's going to change. And actually, a lot of clinics give ibuprofen also, or some other kind of medications, and it's not clearly demonstrated that it has a big impact. Okay, it could have an impact on, for example, the ovulation process in natural fertility, but after the egg retrieval and once, I don't think it's important.
All right, thank you for the clarification once again. And the next one is right here. So at which week in pregnancy should one expect the baby to start kicking?
Well, so if it's your first kicking, it's like, with the legs and that, right? I'm understanding it correctly? Kicking is moving and that you feel it, right? Yes, moving. Okay, thank you. So if it's your first baby, normally it's later. It's like at the 24 week, okay? And could be even later. Don't worry about that. In some cases, some patients tell us that they have feel it before with 17, 18 weeks. It depends also in the weight of the person and on where the placenta is, because if the placenta is anterior, so the baby needs to do a very big movement so that you can feel it, because the placenta is in between you and the baby, okay? But probably I would say with the first child, 24 weeks. With second child, it normally is before. It is before, but it depends also on where the placenta is.
All right, of course. Again, thank you so much for that confirmation. And one more from Angela. Okay, let's have a look. At which week in pregnancy should good quality fish oils, white cod and tiny, be stopped before the birth? I have read conflicting information on this.
So I'm not aware of that. I mean, what I do know is that some supplements have good quality oils, okay? And actually that, for example, the omegas and all these things are very, very good during pregnancy. And that have not any bad impact on the pregnancy. And actually, I know that a lot of the supplements of pregnancy have this also. I'm not sure about wild cod and tiny because I don't know exactly, but I will look at that. I cannot help you a lot with that question because I don't know actually a lot about that. I will take a look on that. Wild cod and tiny.
Of course, thank you so much indeed for that. So once again, someone is typing, so let's have a minute and see if we have another question. Or yeah, it is. So let's have a look at this straight away. So is drinking coffee a bad idea when trying to conceive?
Is drinking coffee a bad idea when trying to conceive? Well, I mean, I would say between 1 and 2 coffees, it's not, it probably doesn't have an important role. Actually, caffeine and coffee has also antioxidative effects, okay, so antioxidants, so it could also be good. But I mean, about caffeine, that's what we would say, like probably 1 or 2 coffees with caffeine a day would not be a problem when trying to conceive, and neither when you become pregnant during pregnancy. 1 or 2 coffees a day should be okay.
All right, again, thank you so much. Okay, yeah. Sorry, there was a follow-up. Sorry, there is a thank you from Anna first. And we will go back to the previous question from Angela, yeah? So some say 32 weeks, other 36 weeks, so a big gap.
That would be about the first question, right? About the oil.
Yes, exactly. Sorry.
Yeah. I don't know. I will take a look on that because I probably don't understand correctly what you're meaning.
Okay. Yes, Angela has added. Yes. Okay. All right. So we will need to leave this at the moment. But of course, I think now we will have our final question. Okay. If you wish to ask anything else, go ahead and do it now. We can still answer some of your questions, but let's have a look. So what is the age limit for treatment in your clinic with own eggs and also donor eggs?
Okay, so let's start with the easy answer, which is with donor eggs and general treatments. It's up to 50 years, so the day before you become 51 years old. Okay, but I would strongly recommend you to avoid to wait that much and to go for a pregnancy before, even if you're using egg donor. Okay, because pregnancy can, I mean. A pregnancy after 40 years or after 45 years can be a high-risk pregnancy, and you can have more preterm deliveries, hypertension problems, diabetes problems. So I would strongly recommend you to try to conceive before. Okay, I mean to get pregnant before conceive or with egg donation. Okay, but the limit is 50. Okay, then that's like a consensus that we have all the clinics in Spain. Okay, 50 years, and so until the day before 50, becoming 51. And then age limit for treatment with own eggs. So there's not a limit that I would say, but I would not recommend it with 44 and 45. Okay, so absolutely not with 46 years. And with 44 and 45, I mean, 44 we could try if you had a very high ovarian reserve, and if I mean, taking into consideration all the history, everything that you've done before, and I probably would recommend you to go for egg donation, okay? But if you have a very high reserve, patients have very high reserve with 44, 8 years old, sorry, we could try. It depends on every case and every patient. 45 would be a super high limit. I mean, 46, I would not do it, I think. But I mean, it depends on every patient, on every case. We have to be always very clear. I always explain very clearly what I recommend and what are what you can expect of the treatment, because it's very important to know what you can expect. And then decide. But still, with 46, I think it's too much, and 45 probably depends a lot on the ovarian reserve and all the history. Okay, I think 44 would be more or less the limit.
All right, wonderful. Thank you so much indeed for that. This is something that also comes up quite often as well. Okay, one more question here from Angela. Can Spain export embryos made from donor eggs but husband sperm to Australia or other countries?
Actually, I think, for example, if you do a treatment here and you do egg donation, we create the embryos, and then later there's some kind of problem and you want to take your embryos with you, I mean, they are yours, okay? So I don't think there's a problem with that. Of course, it depends on a lot of legislation things that probably my bosses will know better than me about administrative part and that kind of things. But normally for us, it's not a problem. Okay, if something happens and you don't want to proceed into the embryo transfer here, it's yours. I think it would not be a problem. And also, I don't know if Australia has a regulation on that, so I cannot answer to that. But normally when I have these kind of questions in my visits, I just ask the ones that do all this more administrative and legal part, and we go through it and we just tell you, okay? But I mean, I think for us it's not a problem. If you have or you have your eggs here, for example, frozen, and then you want to take them to another country, I don't see why you could not do it, okay? But again, I mean, I don't know if I am missing something. So it's something that we always have to talk with
Yes, of course. Actually, Angela has added some info. Australian is the name of the donor because it's not anonymous for import if used in embryos.
No, then it would not be possible, because here, I mean, egg donation is totally anonymous. You cannot know the name of the donor, so it would be impossible to give you the name of the donor.
Exactly. So I guess this is the part where it's impossible, simply because, of course, the legislation is different between Spain and Australia then.
Exactly.
Yeah. All right, of course. Thank you still for the clarification here. Okay. Okay. If you can have a look at this. So what will be a high AMH at 44?
Well,
there's a follow-up. Sorry, let me just no, sorry. Let's go to this one. Sorry.
At 44, probably talking about nanograms per milliliter. With 44, 2 nanograms per milliliter would be a super good AMH. Talking about nanograms milliliter, I'm used to do it like that, not with picomoles. I always have to convert it to see exactly the levels on nanograms. So talking in nanograms, it would be 2 would be a super good. 1.5 would be also a very good number with your age, okay? Actually, with 44, the AMH should be much lower than that, okay? But a high AMH would be like 2, 1.5 or 2 would be a high AMH for 44 years old. Probably less than that, eh?
All right, of course. Thank you so much indeed. And I already showed you, I thought that it's the same patient, but it's a different patient. Anna has added AMH 35, age 39. Is this sufficient or too low?
I have always to convert this to the nanograms. Do you have it in nanograms? I think it would be a good amount. I'm trying to count it. I think it's a good amount with 39. But still, I would look at it carefully with my calculator and look at it if it's correct. I mean, just that you know, what's a high AMH and what's a low AMH when talking about nanograms. Okay, sorry, because I have this the nanograms in my head. But when we talk about nanograms per milliliter, low ovarian reserve would be less than 1.2 or 1. Okay, and a optimal ovarian reserve would be more than 2.5 nanograms per milliliter. That would be a very good AMH. But for example, we have different kind of patients, and for example, with PCOS patients, we have very high AMHs, much higher than that, even 4 or 5. I have seen one of 7 nanogram per milliliter, which is very, very high. Okay, so it depends a little bit on all the history. Okay, but in general, the AMH level, we look at them regarding also to knowing these levels of the AMH. And of course, we do know that they vary between ages, that they vary between labs. So it's not clear, it's not easy to say a direct number with 39, 38, 40. There's a lot of data, and it's there's not a consensus to say this is more or less. But what in which we have a consensus that less than 1.2 or less than 1 would be a low ovarian reserve, a low AMH, and more than 2.5 would be a very high and optimal ovarian reserve. Okay, so the normal range would be around those between.
All right, thank you indeed for that once again. And we will be finishing, okay? Someone is typing, so let's have a look. But of course, we do have already some thank yous. Yeah, it's a thank you from the patient for you right here. One of the patient, and there's the second one, and there's another one here. So thank you so much indeed for that. We will be finishing. But of course, remember that if you wish to get some more details from Dr. Anna and her team, you know what to do. You will be redirected to Dr. Anna's profile on our website. But of course, I'm sure you can also reach to her and her team, and I'm sure, more than sure, that they will be happy to help you out with any questions that you might have. And one more thank you for you, Dr. Anna, from our patient. Thank you very much for a great presentation, detailed answers. Yes.
Thank you very much.
This is something I would like to say. It's exactly the same. I mean, so before I let you go, Dr. Anna, anything else you would like to add?
Nothing. Thank you very much for your questions. I hope to have explained it as clear as possible, because my English is not perfect. So sometimes it's a little bit more tricky to explain things in another language. And if you need anything of us, I mean, I would be happy to answer more questions if you have it. I will look at the thing about the oil also. And well, and nothing. I hope that it was clear and that it was a little bit useful.
It was definitely a brilliant session. So thank you so much for everyone for all of your questions, because, you know, I love this back and forth question answer thing, simply because, you know, there are so many questions that you have, and sometimes you can surprise with those questions, right, Dr. Anna? Those questions can be quite surprising. So so we are even more happy when we get that, because of course that means we can help you a bit and also find out a bit more on other things ourselves, I guess, as well, in a way. So thanks a lot for that. And of course, as you know, we will be back here tomorrow at 8 p.m. UK time. There is another topic. Now we will start with male reproduction topics. I'm very happy to be able to provide you with all those topics that are coming up very, very soon, starting from tomorrow. And Dr. Anna, once again, thank you so much for joining us, for your answers, and it's been great to have you back for sure. And as always, remember it has been recorded, so you will have a chance to watch this once again on my IVF Answers. As you know, there are like over 300 IVF webinars already on our site, so there are plenty of topics to choose from. So if you want to find out some more, go ahead and check it out. And well, as you know, plenty of more events are coming up also starting from tomorrow. So go to our Facebook or Instagram and you will be able to see some other topics. And another doctor from Reproclinic will be with us actually next week. So also just have a look and check it. So thank you so much once again. Take care, everyone. Have a lovely and relaxing evening, Dr. Anna. A pleasure as always. Thank you so much.
Thank you very
Bye.
much. Bye, 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 everybody.